My name is Elizabeth Manns, and I'd like to welcome you to the April 4th Coalition Show. This is the March 27th, 2023 edition of the show, and it has been 446 shows since we've done since the closing of the North Adams Regional Hospital. Our mission statement is for the April 4th Coalition. We are for workers' rights and collective bargaining rights and are against tax breaks for the rich corporations who ship our jobs overseas. We support all the articles of the Universal Declaration of Human Rights, but as is the custom, we put the emphasis on Article 23, and we have a special guest this week on the show, Rachel Branch. So she's going to do number 3 and save me having pronounced that word that shall not be named at this point. So,
I think you want to number it. If you want to do
No, by all means. I'm more than happy to let you pronounce it correctly for us.
That's an inside joke we have.
Okay.
So we'll get started right now?
Yes.
Yes.
Article 23, the Universal Declaration of Human Rights, Article 1. Everyone has the right to work, to free choice of employment, to just and favorable conditions of work, and protection against unemployment.
Number 2, everyone, without any discrimination, has the right to equal pay for equal work.
Number 3, everyone who works has the right to just and favorable remuneration, ensuring for herself or himself and his or her family an existence worthy of human dignity and supplemented, if necessary, by other means of social protection.
Number 4, everyone has the right to form and join trade unions for the protection of his or her interests.
And as is tradition, we give a thank you to Michael Putnam, who I believe is still the Community Radio Program Director for WMNB LP 107.1, for airing the audio portion of our shows at 6 p.m. on Fridays. And of course to Dave Fabiano and his staff for helping us produce the show.
Yes.
Okay, and even though my numbers don't match up correctly because we skipped a large period of time taping the show, I believe we are approaching the 9th anniversary of the closing of our local hospital.
The North Adams Regional Hospital, with only 3 days' notice, on March 28th, 2014, and the 3 of us are part of this still course steering committee. We wish that Mike Wilbur were here to join us. But I will put a little plug in. NBCTC has been showing the 4 programs that I did on Solutions Rising with Mike Wilbur, Paul Donovan, Dr. Donovan, Maynard Cedar, and then Maynard and Paul Donovan together, as well as Rich's son, Peter DeSadi's documentary, and that ran on Saturday, and it will be running tomorrow, March 28th, on the actual anniversary of the loss of our hospital. So I hope you didn't mind that I put we're connected. The April 4th Coalition
is always connected, yes.
Yeah.
So what we thought we'd do today, and we're grateful that Rachel could join us, and you know, this is it's an anniversary for me. It's also 4 years since my brother passed away, and I saw the treatment that he got in his community hospital, and I saw how much that we were losing the way he was treated at his hospital in his last days, to the extent where they even allowed his son and daughter-in-law to be married in the hospital, so my brother could witness them getting married. They put together, let them use the cafeteria, and they had a service right in the hospital, and my brother died, you know, about a week later. But that was,
See, I didn't even think of it in March 18th, 2004, in the brand new critical care unit is where my mother passed away. And I think probably all of us were born in the North Adams Hospital and lost family members there. And the care was phenomenal.
yeah.
I'll caveat, I'm a Pittsfield baby, so I was born down in, I believe, and this hospital no longer exists. I believe I was born in St. Luke's Hospital.
Oh my goodness.
So that's a hospital that closed. And what
That's
we're
a
going to
hospital
do is
that
we're
closed
going to
in
take a look at a few videos. And this first one that we're going to show is how the closing of small rural hospitals is contributing to a bigger maternal health crisis. So this is by NBC News. It was done on October 11th of last year, 2022. But let's watch that, and then we'll give some reaction to
More than a decade now, rural hospitals have been shutting down their maternity wards. These medical facilities are closing their units in part because of financial struggles and low patient numbers. But closing these units could put expectant mothers in real danger if an emergency happens. NBC News correspondent Stephen Romo has this report.
I had woken up at around 11:30 and I stood up and I was bleeding very heavily.
During her second pregnancy, Rachel Tuberville's condition became harrowing in just a matter of minutes.
I was experiencing a placental abruption and my baby was having heart decelerations.
Within an hour of arriving at Sharon Hospital in rural Connecticut, Rachel had an emergency C-section to deliver her son Colin.
I think that being so close to a hospital made it possible for everything to work out the way that it did.
But that care might not be available much longer for expecting mothers in Sharon. The hospital's owner, Nuvance Health, is currently seeking regulatory approval to close the maternity ward. In a statement to NBC News, Nuvance said it has faced continuous financial challenges and low patient volume in the labor and delivery unit. But for most people, that would mean a 45-minute drive to the nearest hospital at least.
Time is of the essence.
Dr. Howard Mortman delivers babies at Sharon Hospital and has a private OB/GYN practice. He was part of Rachel's care team after her pregnancy.
She's another example of if Sharon Hospital isn't there in that proximity, I don't know that Rachel's around. I certainly don't know that her baby's around.
Dr. Mortman also has a more personal connection.
My sister, Gail, she is disabled because of delay in care at her birth. And I said, I'm going to become an obstetrician. I'm going to dedicate myself to preventing what happened to my sister, Gail.
But maternal care has been disappearing from rural communities for more than a decade. In 2004, 898 rural counties did not have hospital obstetrics units. By 2018, an additional 200 rural hospitals were without labor and delivery services, according to researchers.
We're in the midst of a maternal health crisis. The CDC tells us that about 60% of pregnancy-related deaths are preventable.
Experts say rural hospitals in America are more prone to staffing and financial challenges because they serve a higher proportion of low-income families in areas with fewer births.
These vital resources are leaving communities that often need them most.
Back in Connecticut, Sharon Hospital must first get approval from the state to end birthing services. But Connecticut's Office of Health Strategy confirms to NBC News that they're actively investigating whether Sharon Hospital illegally terminated its birthing services without a state-required certificate of need. In a statement, Nuvance Health said that Sharon Hospital was committed to working with OHS and that they have closely followed the process required. But as we await a decision from OHS, the labor and delivery unit remains fully open and operational. 4 years later, Rachel says she and her son are both perfectly healthy.
To me, it's scary to think about what could have happened with that extra hour added onto an already very scary situation. I don't really know what would have happened.
And we should mention the U.S. has the highest maternal mortality rate in all high-income countries. And as for Sharon Hospital specifically, the next step in the process is a public hearing that's set to take place this month so members of the community can weigh in about what this closure would mean for them. Back to you.
Well, the first thing that strikes me is that last statement. We had a hospital
Will
close
close.
without a public hearing.
True.
We didn't
did.
have a public hearing.
No.
Illegal 3-day notice.
Illegal 3-day notice. And you think about the mother, that extra hour?
That's
They
like
probably would have had to do a C-section, emergency C-section in the ambulance on the way to transporting, assuming she was able to get an ambulance to transport her.
So if you live in Florida Mountain or Monroe or rural parts of, Clarksburg or whatever, and you're trying to get to a hospital, it's a long ride to
It's a long
Pittsfield.
ride to Pittsfield. It's clearly, it's in bad weather, it's well over an hour. Even in good weather, it's 50 minutes. I'm sorry, you can't bomb up those mountain roads to get anywhere.
No, you can't. And you can't in the winter.
And it is a poor statement of our society that we do not invest in taking care of women and children in this situation above all. you say you're pro-life, but yet, you know, let's close hospitals so that women who you won't let avoid getting pregnant or, you know, have birth control, but yet you're willing to close the hospitals on the other end, which endangers their lives and certainly any newborn baby in coming along in that area. You know, we're supposed to be one of the richest countries in the world, and we can't solve
I keep saying
it.
this is the United States of America. Nobody should be hungry. Nobody should be without housing. And this, I look at this and say, this is another assault on women and children, and to be giving birth and not have care is just egregious. I'm running out of words to use.
I love
what has
egregious.
happened. Yeah, I like that word. Unconscionable is another
That's the
one, but
one
I
you like.
overuse.
Yeah, I love them both
overuse
because
that,
they actually cover multitude of things. I mean, and this one is seriously lack of neglect, and I'm always amazed society doesn't get up in arms over this. I mean, when ours closed, we had high energy until the report came out, and then it was like, oh well, it's all over with, boom. They said, no, we're not big enough, we can't make a profit margin out of this. So, yeah.
There it is right there, Liz, just what you said, the profit margin.
Right.
Whenever did hospitals talk about profit margin? This is pure greed, absolute greed, and I've been saying all along, this is a systemic, structural problem. And when I saw one government office in Connecticut coming after Sharon, like, what are you talking about? This is, where is of the people, by the people, for the people? Where is this?
Where is it? It's not
And
there. Go ahead, Dick.
We tried to get back to the maternity aspect. My maternal great-grandmother was a midwife in the old country, but then here in the United States too. She delivered babies in Monroe Bridge.
Oh my goodness.
So, you know, I thought when we had the hospital closed, we didn't have a maternity section, maybe we could get midwives to come and practice here. And I made a call to the National Association of Midwives, and they said, well, you have to be so many miles from a hospital, like 5 miles from the nearest hospital in order to, but you can get an exception, and maybe we would get you an exception. But I called the midwife who was in South County, and she said, yeah, we might get the exception, but I, as a midwife, would not want to practice if I wasn't close enough to have the hospital close enough to save
the baby.
The baby in a situation.
If there was,
so I wouldn't practice there, which is the same words that we heard from that doctor from the University of Massachusetts, Harvard graduate, Williams College graduate, who said that, you know, if I don't have a pilot's license, I'm not going to practice as a doctor if there's not a hospital within 10 to 15 miles from my office. And
Correct.
so that, you know, so
it's a famous catch-22.
We need rural hospitals need help, and I think maybe if we can just move to the next video, because it's about rural hospitals on life support. It's a disaster in the making, and this was
and
again,
I think it's by design.
Yeah, it was from October 4th. It's called by Medscape. So let's watch that video and see if it spurs on some more discussion.
Access to care in rural areas has to be involved in any conversation about public health. Yet we don't often hear about the incredible work being done in rural hospitals and the struggles they go through, even though 20% of Americans live in rural areas and depend on those health facilities. Now, rural hospitals, like all hospitals, have their share of funding and staffing issues. So when I initially saw headlines about the Rural Hospital Rescue Program, I was excited. And then I read about it and I was confused, to say the least. Let's back it up really quickly. Now, I'm not going to get into a big healthcare economics talk, but let's talk about what's happening with rural hospitals financially. Since 2010, 135 rural hospitals have closed, with the majority closing between 2015 and 2021. And it's actually getting worse. As of right now, about 450 rural hospitals are at risk of closing. And here's some alarming data. According to an analysis of the Rural Health Safety Net by the Chartis Group, 46% of rural hospitals have a negative operating margin. And in some states, it's particularly bad. In Alabama, Kansas, Missouri, and Arkansas, for example, 70 to 80% of rural hospitals are operating in the red. Now, going back to the Rural Hospital Rescue Program, the plan is to get rural hospitals to close all inpatient beds and instead focus solely on emergency and outpatient care. In exchange, rural hospitals get a monthly stipend and an increase in reimbursement. The thought is that unused inpatient beds in rural hospitals cost them so much money to staff and maintain that closing them would save on overhead and potentially prevent closures. The way this will all work, according to the Centers for Medicaid and Medicare Services, is a rural hospital would have to apply for a designation as a rural emergency hospital by essentially closing all inpatient beds. They would then be eligible for a 5% increase payment per outpatient service and a monthly facility stipend, which is set to increase in the future based on the market. Now, given the fact that for the average rural hospital, about 70% of the revenue comes from outpatient services, this plan might actually increase the hospital's bottom line. Now, CMS has yet to release all the details, including more stipulations about the stipend, but this plan is already being met with a lot of questions and confusion about how it's even rational to close inpatient services in rural hospitals. So I asked around to my colleagues from multiple subspecialties, and nearly everyone had a story in which a rural hospital needed an inpatient bed. Now you might say, well, hey, what about crash inpatient beds or long-term observation units in the event of an emergency? Well, according to a proposed rule by CMS, flexible swing beds will not be allowed for any hospital that wants that rural emergency designation. Really? Why not? I have so many concerns. I work overnight in the hospital. I often get calls from a transfer center from rural hospitals, but the patients don't always come over. Sometimes rural health doctors are comfortable taking care of patients, but just want to check in with a tertiary care center. Sometimes the patients themselves don't want to be transferred. Sometimes it's just something like an outpatient surgery that needs overnight monitoring. Sometimes weather gets in the way and we physically can't make a transport happen. I've even had situations where there were no ambulances or helicopters available, so a patient had to stay inpatient at a rural hospital. Also, look around. A lot of urban hospitals that would normally accept rural transfers are at capacity and short-staffed. This problem's getting worse. We saw an alarming example of this during the pandemic when rural hospitals couldn't transfer acutely ill patients. This is a more complex discussion, but the Rural Hospital Program also mentions nothing about the rural doctor shortage. In rural communities, there's only about one ICU bed per 10,000 people. 160 rural communities have no access to OB services. About 65% of rural communities have no psychiatry, and you can imagine that subspecialty care is also lacking. Simply put, I'm yet to run into one physician or healthcare professional who thinks it's even feasible to close inpatient services in rural areas. I mean, I appreciate the conversation about protecting access to care, but this solution is a little short-sighted. A perspective piece from the American Hospital Association talked about funding and protective efforts for rural areas, such as money directed to rural providers through the CARES Act and American Rescue Plan, Medicaid expansion, even increasing the resident workforce through the Consolidations Appropriations Act. These sound productive. In the end, regarding the Rural Hospital Rescue Program, I suspect we'll learn more details and there will be more provisions. But even still, I find it hard to believe that any hospital administrator is going to opt into this program unless it means the difference between staying open and staying closed, and that would be a harsh reality. But I want to hear what you all think, especially any rural healthcare professionals. What are your thoughts, concerns? I want to hear all of it. Comment below.
Well, that seems
Go
what
for it.
happened to us.
That is what happened to us.
You know, and be interested to know if Berkshire Health Systems got an increase in their
funding.
their
for-
funding
for
because
that.
they got rid of all our beds.
I think my new dirty words are going to be by design.
By design.
By design, and I just looked at that and I feel this rage coming up, and I just think that who's ever making all these designations, like we couldn't get critical care access,
Right.
we can't get beds, and yeah, there's money to invest outside of communities, beds and maternal care and psychiatric care, addiction care, all the things that you really need that are happening in every community
Every
across,
community. Yeah,
across
no.
the country. But I just look at this now with income inequality. connecting the dots. This is by design, and there are a lot of people making a lot of money over not providing us with necessary health care.
Oh, it's definitely the
We
bottom
don't
line
have health
decision.
care anymore.
No, we don't.
We have disease. We're
It doesn't
surrounded by
matter if you have
disease.
insurance if you don't have the medical needs available. I mean, I'm sorry, not everybody can hop on a down to Pittsfield to get the specialty cares. And yeah, wonderful that they rotate one doctor up every week, one day a week to
Well,
come
you know
up.
I won't
but,
go there.
but you know what I mean. But you know, it's still the same thing. There's too many patients who can't get there. You know, when I went for the eye, ear, nose, and throat when we were having that conversation, she suddenly looked down and she said, "Oh, you live up in North Adams. It would be better for you to be up there, wouldn't it?" I said, "Yes, it would be better for me. It'd be easier for me in terms of work instead of losing a day to come down and have a doctor's appointment. I can come to you and then get at least half a day of work in. It would have been better." But I was fortunate to have a vehicle, but if I didn't have the vehicle, I wouldn't have been able to go.
Well, my health care is in Pownell.
Yeah.
And as a result of being hit by a hit and run, I mean, not hit and run, a rear end, I'm in medical care the rest of my life. Part of my care is in Bennington. Part of my care is in Lee.
Yeah.
It's
Because
all
there's-
over, yeah.
And I'm not sure
And I
even
still have a car.
and you still have a car, right? That's the only reason that works
Yeah,
for you.
but you can't depend on the buses, you know.
No, because Berkshire Regional Transit Authority's in financial straits every year. They don't
Well,
get
when I
enough
see all
funding.
this money supposedly for a train from east-west, as my high school teacher, English teacher would say, the exit is on the wrong syllable. You need transportation in our area for people to get to work, to get to medical
Exactly.
care, whatever they need, before you do these great big projects and say that's a drop in the bucket.
Yep.
It's not.
Can we show
You
one
want
more
number
video?
three.
I want to,
Sure.
because it gets into the politics of it.
Oh,
It's
good.
Bernie Sanders had a rally in 2020 in Philadelphia about a hospital closing, and let's take a look at that, and then maybe we'll have some time after it.
As all of you know, the possible closure of Hahnemann has nothing to do with health care. It has everything to do with greed, corporate greed. It is about a national health care system in America which is dysfunctional, because its goal is not to provide health care to all people as a right, but is to make as much money as possible for the insurance companies, the drug companies, and in this case, real estate speculators. That is wrong. That is immoral. That is not what this country is about. We believe that health care is a human right, and we're going to fight for a system that is based on human needs, not corporate profits. Health care is not a commodity to be bought and sold to the highest bidder. Health care is something that every person in this city, in this state, in this country is entitled to because they are a human being. In the immediate moment where we are right now, we stand in solidarity with doctors, nurses, community groups, and local elected officials who are fighting to save Hahnemann from being destroyed by a real estate speculator. But what we must also understand is that this is not just a Philadelphia issue. It is not just a Vermont issue. It is a national issue. Since 2010, over 100 hospitals in the United States have shut down, and if we do not get our act together and put people before profits, hundreds more will soon be shutting down. Make no mistake about it. If an investment banker like Joel Friedman is able to shut down Joel Friedman is able to shut down Hahnemann and make a huge profit by turning this hospital into luxury condos, it will send a signal to every vulture fund on Wall Street that they can do the same thing in community after community after community. We cannot and we will not allow that to happen. And that is why I will be very soon introducing legislation in the Senate to establish a $20 billion emergency trust fund to help states and local communities purchase hospitals that are in financial distress. In my view, anytime a hospital is put up for sale in America, the local community or the state must have the right to buy it first with emergency financial assistance. And I'll tell you what else we're going to do. We're going to end private equity funds from Wall Street vulture from owning hospitals in the first place. And I'll tell you what else we have got to do, and that is the United States must do what every other major country on earth does, and that is guarantee health care to all through a Medicare for all single-payer program.
Well, that is what happened here in North Adams. Massachusetts had the system to buy the hospital.
Yeah.
We just had a governor whose wife worked for Berkshire Health Systems that refused to follow the suggestion of professors and professionals that the state should take over the hospital and reopen it under new management. They allowed Berkshire Health Systems to buy this as a real estate investment at a bargain rate.
May we continue this conversation next week, because it's too important to just end this program without continuing it.
See you next week.
Power to the people.
Yep, that is.
There's power in the factory, power in the land, power in the hand of the worker. But it all amounts to nothing if together we don't stand. There is power in our union. Now the lessons of the past were all learned with workers' blood. Mistakes of the bosses we must pay for. From the cities and the farmlands to trenches.